Year today, he actually has set a new record for frequent flyer for the trauma system. He crashed his bike again. I don't know if it's, I have no idea. He was sober. Yeah. No, it wasn't the naked bike ride either. Yeah. God, he's going to watch this tape. That's all right. I'm sure I'm fired again. But anyways, so Saturday afternoon he was riding with Jeff Clark. And I don't know if all of you know Jeff. Jeff's a PA or was a PA at Med Center for a long, long time, and Memorial. So anyways, they're good buddies. They ride all the time. And he was going over train tracks and lifted his front end a little bit to go over the train tracks and saw his front wheel spin off. We don't know if his skewer busted or if he forgot to clamp his front tire, which very well could be true. So anyways, oh, sorry, there we go. So anyways, he had 5 broken ribs, was transported by AMR, and actually there was two guys at Portland Fire that responded that used to work up here. So he knew the AMR paramedics, so it was like a big, it was almost like coffee or something. They got together and chatted for a little while. Anyways, come out today. Spirits are good. He looks good. I went and saw him on Sunday. Well, he was wasted, and we had a MPD meeting yesterday, and he was trying to record stuff onto a flash drive from his computer. I said, just give it. We'll fix it. Anyways, he's doing good. No, he was in Portland, so we went to Emmanuel. Actually, yeah, we try and separate that out. Thanks for bringing that up, though, by the way. Yeah. So, anyways, that's where we are with that. So, stop by, see him, give him your well wishes. He loves seeing, even if he's in the middle of a procedure or going to the bathroom or whatever, he'd love to see you. It's the way he is. You know that. So.
It's good working with you, Mark.
Yeah. All right. So, with that, thanks. Marlo's going to do lecture case reviews. We're going to have a little study reminder after this, and then we're free to blast off. I know there's been some changes to PCEP lately with the scheduling, timing, the amount of offerings that we have, and the go to training thing. Please don't be afraid to send me your comments, even if they're negative. I don't mind. Let us know how it's working for you, whether it is, whether it isn't, and we'll do our best. So, anyways, thanks.
Good morning, and I just want to assure you all there's been no decrease in the frequency of Dr. Whitwer's communications with me. I have no question he'll make a full recovery. So today we're going to talk about medical legal issues, and obviously this is not the most fun and exciting topic in the world. I would ask that you ask many questions during this topic, because amongst all the things we cover, this is one of the things that is pretty easy to lay out in black and white. The difficulty comes in the gray areas, and the difficulty comes in how we actually apply it. So I welcome you to ask questions, give specific cases. Dr. Bell is here as well, and we'll be able to answer those and work through these things. This will be a reminder of things that you've heard before, but things that we deal with every day that have potentially significant implications. So first we're going to talk about refusal of medical assistance. So,
Before you get started, here, open that up again. Actually, click. Yeah, hit. Oh, you know what? It's the connection.
problem with the connection?
Yeah.
Okay, I turned off the webcam to use less bandwidth. And
Okay. Yeah, because that needs to come back on.
It's not showing the screen right now.
Yeah. Yeah. Huh. Yeah.
Okay. So it sounds like the people who are remote right now are having trouble seeing the screen because of the speed of the connection. Okay.
Okay. See, now that's good feedback. We can, yeah.
That's terrible.
Yeah, it's because of the
Hello? Hello?
So they're not able to hear.
Hello? So it should work. There you go. There you go. We should be working.
Okay. But we still got it. So for the people who are watching remotely, are you able to see the screen right now? Respond through chat.
They're good.
Okay. Okay. Thank you. So refusal of medical assistance. For a patient to refuse medical assistance, they need to be able to give informed consent. We'll talk about what that means. To refuse care, we'll talk about the elements of informed consent, go through the matrix of transport decisions, talk about when to apply patient restraint, and general guidelines for non-transported patients, plus the Clark County protocols. We'll also cover other issues involving refusal of care, specifically post and advance directives, issues in documentation, and then other legal issues affecting the practice of pre-hospital care. Psychiatric disorders we covered 2 months ago, and we'll talk about how they affect these issues. So informed consent is critical to the process of informed either refusal of care or acceptance of care. The reason behind it is that we're trying to protect the medical decision-making autonomy of the individual patient. And it's an information exchange between the patient and the healthcare provider. So this idea has become more prominent in medicine, and I think if you talk to people who are in their 70s and 80s, and I notice this in my daily practice, they much more want to be told what to do as a general rule, because medicine used to be a more paternalistic practice where the doctor said you do this and you do this. And I think now the model that we use is shared decision making, that you are able to give the patient the information, and then the patient is able to take that and make a decision that matches their values. And so informed consent supports that shared decision making. And the idea of informed consent was enshrined into the law in this 1914 Supreme Court decision where Justice Cardozo said, every human being of adult years and sound mind has a right to determine what shall be done with his own body. The case in 1960 involved a complication from a procedure. And so if I'm getting ready to do a spinal tap on someone or to put a central line in, I have to tell in simple language what could happen, what are the things that could go wrong when I do a procedure, and what are the potential complications. And similarly, so transport is a procedure. There are things that can go wrong if you do transport someone. There are things that can go wrong if you don't transport someone. And then with individual treatments that we apply in the pre-hospital setting. The 1972 case is related to the patient's right of self-decision. So it means that we as physicians and then paramedics as the extension of physicians have a duty to reveal all the information. So if there's some risk of the procedure that we don't disclose, then we haven't done our full duty in terms of informed consent. So where this becomes most difficult is the patient who either cannot make an informed decision because they're incapacitated in some way, or because they're refusing care or transport. I want to clarify competence and capacity. So competence is a legal definition. It's a legal test that's determined by a judge about whether the individual can retain and comprehend relevant information, whether the individual is able to believe that information, and whether they're able to use that information to make a choice. So we as physicians, as paramedics, we do not determine competence. What we do determine is decision-making capacity. So it's a presumptive determination of competence, and it has to do with what exactly they're understanding and what they're potentially accepting or refusing. So if we think that the patient doesn't have the capacity to understand the implications of the choice, then we can conclude this person doesn't have decision-making capacity to make this decision. And that can be, we can base that on information from the patient and their own actions. We can base that on information that we get from caregivers or relatives. So to establish capacity, you have to be able to determine whether the patient understands the nature of the condition, and then what are the consequences of refusing treatment and or transport. So to have decision-making capacity, you need to be able to think through it. So for example, someone who has significant dementia may have a deficit in cognition and not be able to have capacity for that reason. You can have a deficit in judgment. So someone who has spent the entire weekend smoking methamphetamine, spending all his money, and doing other crazy things, has significantly impaired judgment. And this becomes very difficult because we have to respect the patient's right to make a bad decision, but if they have significantly impaired judgment such that they wouldn't be able to make any reasonable decision, that's a case where we may determine that they do not have capacity. We need to determine that they understand what it is that we're saying to them. So whether it's because of a hearing problem or a language barrier, that they can't understand what we're trying to get through to them, that can prevent them from having decision-making capacity. They have to have a choice. And that can be whether the family is making pressure on them, whether they feel that they are being given an adequate choice. They have to be able to express that choice, and their medical stability comes into play. So if you have someone who's hypoxic and hypotensive, it's hard to say this person has intact decision-making capacity. There's some physiological impairment that keeps their brain from being perfused. So it's when we get into trouble with this, it's not so much the patient's decision, although that has an impact, but what we need to focus on in our charting is whether the patient had decision-making capacity. And then if we determine that the patient has capacity, then they have the right to make a bad decision or a decision that we disagree with. So this particular doctrine comes from this Lane versus Kandura case. It was a 77-year-old woman who had gangrene of her leg, but she otherwise had multiple other medical conditions and did not want to live as an amputee. And so although the physician felt that he could save her life by doing an amputation, she did not want to live with an amputation. And so ultimately there was a court ruling supporting the patient's right to determine the treatment. And so the patient can refuse a potentially life-saving treatment, and that the patient had the capacity to make that decision. You can imagine, particularly on scene, these can be very difficult decisions to make, particularly when we're dealing with figuring out what the implications of that decision are. And so, as you'll hear us say repeatedly, these are cases where you do not want to hesitate to involve online medical control. So to give informed consent, you want to make sure that it's an autonomous decision. So, for example, if you have a family member who, say, doesn't want this patient to do well or has some ulterior motive, and they're putting pressure on the patient, that's an example of something that would not be an autonomous decision on the part of the patient. You need to have a capable individual, someone who can understand the information, is able to understand the information, and repeat that back to you. You have to disclosure of the information by the provider. You need to be able to give them the information about the risks of refusal. And I think that is something in particular where online medical control can be particularly helpful. I think we can all, something that's straightforward, someone who's having a STEMI who refuses care, I think anyone in this room would feel very comfortable talking about the life-threatening risks of what's going on with that. Now, sometime, for some reason, some patients, and I've experienced this on both ends, won't just, will listen to a doctor in a different way, and that can be another tool that you can use to convince someone. There are other cases where it's confusing. You've got someone who's got some weird disease and is having some odd presentation. That's another case where a physician can be really helpful. And then you want to ensure that the individual can comprehend that information. And a good way to verify and document that is to ask them to repeat it back to you, and not just parrot it, but to say back in their own words what it is that they're either accepting or refusing. So there is a sliding scale standard with comprehension, especially as we determine capacity. So the example I use of this is that someone, if someone, say, had some beers earlier in the night, but now they're sober and they've stubbed their toe, or they have a small hand laceration. That's what they need to understand to refuse transport is very different from the person who's in the same physiologic situation but has a knife in his chest. Whether you understand the risks of getting your hand sewed up or not, or getting an x-ray for your foot, is very different from understanding the life-threatening risks of having a knife in your chest. And so when the care that they're refusing has more significant implications, then it puts more pressure on us to say this person has the capacity to absolutely understand the life-threatening risks that they're taking, and I cannot take them against their will because they understand that and they still want to refuse care. Dr. Buck, could you add anything to that? Or?
No, I agree that it's kind of a gradation of the seriousness of the presenting problem.
So and that's, again, particularly in the odd cases or patients with odd medical history, that's a situation where a physician can help you determine exactly how risky this refusal is. In general, the decision to refuse ambulance transport is, of all the medical decisions that a patient can make, it's generally a fairly high-risk decision. Now, obviously, more high risk in someone who's got penetrating trauma or a STEMI versus someone who has a minor injury. But in general, just like one of the highest risk things that I do every day when I go to work in the emergency department is discharge someone from the emergency department. To refuse EMS transport is a potentially high-risk intervention or potentially high-risk decision on the part of the patient. So we're going to go through this matrix of transport decisions. So on the top, we have whether the patient desires transport, and on the side, whether EMS desires to transport the patient. So if both parties are in agreement, that's fairly straightforward. If EMS is recommending transport and the patient is refusing, that's a refusal of medical assistance. If the patient wants to be transported and EMS does not want to be transported, it's classified as a denial of aid. And if neither the paramedic nor the patient wants transport, then that's just straightforward no transport. And so obviously it's these issues.
Sorry, I was just saying, validate is a different thing. When you look at somebody, it's pretty obvious, they're in Salmon Creek and they just want to ride to the hospital on Milkman so they can force you a taxi cab.
Right. No, that is. I mean, this situation where there's for the people who are listening remotely, the comment was, say you have someone who's at Salmon Creek and wants to get a ride to Mill Plain, or we've had this happen, someone who calls 911 from the waiting room. Those are potentially different situations, and we'll talk through how to approach those situations. But it's these situations where there's disagreement that are the most difficult ones to resolve. So if the patient refuses and EMS is recommending transport, then there's a refusal of medical assistance. And what's incumbent on us as the pre-hospital system is to advise of the need for treatment and transport, and that the patient has capacity to refuse despite understanding the risks. If the patient is requesting transport and EMS disagrees, there's significant liability associated with that. And so that's something that we need to approach extraordinarily carefully. If the patient refuses and EMS agrees, so the example here is an MBA where the patient did not call, a bystander called to ask for help, and the patient and the paramedics agree that there's no illness or injury. And so the one thing I will say is that it is very helpful, say you go on a multiple car accident where there are no injuries, just to write a narrative that said, I saw 3 people who were at this site, all were up walking around, none had any complaints. Even a very brief narrative can help us if we have to look into the call later. Now, if you initiate patient care, if you take vital signs, if you provide a diagnosis, if you say, you're going to be okay, because you are, just by looking, you start to assess someone, and if you then, lay your hands on the patient and start to engage in this medical relationship, then someone becomes a patient, and you want to err on the side of making them a patient. And you can make them a patient and then say that they ultimately have a reassuring exam and it's reasonable for them to decline care. But the key places where people get into trouble with this are either not doing a quick narrative on some case where no one is injured, no one has complaints, or doing something that crosses the line into patient care and not doing full documentation of a patient encounter. Questions about that?
Looking at the patient, just looking, they've been told before constitutes a form of assessment.
Yes, but so we're not suggesting that so the question from the audience was, looking at the patient constitutes a form of assessment. Obviously, we don't expect you to walk up onto the scene blindfolded and then only have the patients come up to you. And yes, you do make judgments. And if you find, say you look at someone and you see that someone's stumbling or ataxic, that's looking, and that's a form of assessment. If you look at the patient and you introduce yourself to the patient or the person who's at the motor vehicle accident, and they say, no, I'm fine, I'm not injured, I didn't call, I didn't ask for help. So yes, you made an assessment that this is an awake, alert, talking person who has no complaints. I think it's reasonable to call that person not a patient. If there's any question, if someone says, my neck was hurting and now it's better, if there's any question, you're much better off documenting a full patient encounter. Does that answer your question? Okay. So refusal and restraint. So false imprisonment is restraint without proper justification or authority, or unjustifiable detention of an individual without his or her consent. Assault is unlawfully placing an individual in apprehension of immediate bodily harm without consent. Battery is unlawfully touching an individual without consent. Abandonment is when you prematurely terminate the patient-paramedic relationship and you're not following the steps that are necessary to ensure the definitive care of that patient. Reasonable force is the amount of force required to ensure that the patient does not cause injury to himself or others. So when we're not transporting a patient, so if a patient is refusing transport or if there is no patient. So this would be no patient found at the scene. That's the false call you get someone calling from a cell phone saying there's someone down at this intersection. You go and you find that there's no one there. That's fairly straightforward. Now, these situations where you have DOA, death in the field, termination of a resuscitation, those obviously require full documentation, and you're not transporting that patient, but you're fully documenting that encounter. So patients who are refusing care, we've talked about the patients who have no medical need. We've talked about the patients who have normal decision-making capacity. You inform them, and they voluntarily decline. And then there are patients who have impaired decision-making capacity. And so these are, I think, some of the most difficult situations we deal with, where you have a patient who is impaired and has a need for medical care. So this can be an inability to understand the nature of the illness or the consequences of refusing. Some causes are alcohol or drug intoxication, psychiatric conditions, head injuries or shock, organic brain syndrome, such as someone with Alzheimer's or another kind of dementia, or someone who has a mental handicap, so for example, someone with pervasive developmental delay, minors, and then a communication barrier. So to have informed consent or refusal, the patient needs to be given complete and accurate information about the risks for refusal, benefit of treatment. They need to be able to understand those risks and to make a decision consistent with their beliefs and life goals. So for example, if you have a patient who has terminal cancer and is on hospice, the decision to decline transport for something that's potentially life-threatening is clearly consistent with their beliefs and their goals. So if you have someone who's capable of making a decision, there's no medical need, so an uninjured patient in an auto accident, patient did not, or an uninjured person in an auto accident, someone who did not call, a refusal form is not necessary for that, but document the events that led to the call and the criteria that there was no patient need, that there was no patient or no medical need. So whether it was a bystander called, the person was sleeping, awoke, had no complaints, had clear speech. Just that a brief narrative describing what you found at the scene is vastly more helpful than a blank chart saying there was no patient. So if there is a minor medical need, say this is someone with a hand laceration, an arm laceration, and there's a reason you got involved, we do ask for a form refusing care for this patient. So document the chief complaint, the reason for the call, permanent medical history, relevant portions of the scene, the physical exam, any treatment provided, could be bandaging, could be someone who had a mild asthma attack and who ended up getting albuterol inhaler, and then information about what the consult you gave them, what risks you talked to them about, and instructions for the family about what the risks are of refusing treatment. So now we're going to talk about the situation where there is immediate care or transport needed. Someone who has a definite need for medical intervention. You obviously want a refusal form. You want to document what you did to convince the patient to receive care. I think one of the most powerful things that you can document when you're in a situation like this is that you involve the family. That you said, you said to the patient's wife, I really think you should go to the hospital. The wife may agree with you. The wife may say, I really think you should go too. Can you please talk to him? Can you please try to convince him? And then if you write in your chart that the wife could not convince him, the wife and the patient's 5 sons and daughters tried to convince him to go to the hospital, and they could not convince him to go to the hospital, that's very powerful, in part because if these become medical legal cases, it's often from the family, so that's a powerful defense. It's also the right thing to do for the patient. You want people who know him to remind the patient of his decision-making, his goals, and try to do that. You can also get help from law enforcement, may be helpful convincing a patient to go, a mental health professional, clergy. These are cases where you absolutely want to make contact with medical control. As I said before, having the additional weight of the MD behind your name telling that patient sometimes can convince the patient to go, and also makes a clear case when someone looks at your chart. I tried to get the family to get him to go. I tried getting the doc on the line, trying to convince the patient to go. I tried all these things, and I was unsuccessful in convincing the patient to accept medical care. And then you want to explain the refusal form to the patient. Yes, sir.
In the event of an injury that needs imminent treatment, and they're just being stubborn, young, invincible kind of guy, but says he just simply doesn't want an ambulance, so he'll go to the hospital if his family takes him. Is there any gray around that consulting of medical control as far as taking that time to do that versus the extra few minutes he'd already be en route?
Right. Just so I can answer your question, are you talking about someone who's got an immediate life-threatening condition, like penetrating trauma, or?
No, I'm talking about a kid that took a rope swing off the lake, and they figured he was about 25 feet in the air, and I was pretty sure he had a hemo developing already as he was coughing up blood.
Okay.
Blanched out skin on his left side.
Mm-hmm.
He simply would not go. And
Okay.
so I just told his girlfriend to take him. He said, I'd go with my girlfriend, I'm just not taking an ambulance. So I didn't even bother with medical control. I just told him, this is your refusal, sign right here and get your car and go.
Right.
He called afterwards. Didn't have any issues with the doc, but what's the gray area?
Right.
Cool with that? Actually,
So the
judgment thing that you're
Right.
okay with?
So I'm going to repeat the question so everyone can hear. So the question was, what if you're in the situation where someone who doesn't have has a potentially life-threatening condition and is willing to go with family, but is not willing to go in an ambulance? How do you weigh the risks of the additional time that involve getting the physician on the line versus the time that they could be en route to the hospital? So the way I would answer that is, we have studied this, and when patients say they're going to take their own car to the hospital, it's about 10 to 20% of the time that they actually get to the hospital. And so, and that's even, despite them looking you straight in the face and saying, I'm going to go straight there, I'm going to, there's going to be no delay, I'm going to go straight there. I had patients just forget, stop at McDonald's, have the car break down. And so I would, in my mind, in general, I would treat trying to go by private vehicle as the same thing as refusing care. I would try. So the way I would answer that is, I would try to make it as quick a call as possible, but it's difficult to make the case that you gave them a complete informed refusal when you haven't followed that step of getting medical control involved. If you're in the situation where, you know, that's the only thing you can do, then I would document that I felt that the risks of delaying the private vehicle transport to contact medical control outweighed the benefits. But I think you're on fairly thin ice when you do that, because in actual effect, even the patients who really swear they're going to go don't often go. And so I would recommend contacting medical control. You can make it a quick call, and you can say, look, doc, I'm calling you that I think they're on their way by private vehicle, but I'm worried about this guy. Can you have a quick conversation with him? There are things you can do to limit the time of that call, but I think you're on thin ice if you don't make that call. Does that answer your question?
Yeah, and you're right. I couldn't give them a complete review or consent because in my mind, I didn't want to do that. I literally told him, listen, you're saying no, and I'm telling you you need to go, and sign right here because I don't want to lie.
Yeah.
That's what it came down to.
Yeah, and I know there's some patients who are very belligerent, who won't sign the form, or who won't wait to talk to a doc. But you just want to make every effort to make an expeditious medical control consultation in that case. Okay, and then so this is a little bit more detail on the patient who is not capable of making a decision, but transport is necessary. So even though the patient doesn't have full decision-making capacity, you're still going to try to do everything that you can to convince the patient to accept care. These are cases where you're going to consider physical restraint and sedation. Again, if you're making this decision, especially if it's a gray area, there's no reason that you should be unsupported in this decision. Consult medical control, particularly if you're in the situation where you think, I'm going to have to take this person against their will. That said, your primary job and your most important job is to come home safely every night. And so this has to be something that you feel that you can do safely. Contact medical control for the orders to restrain, treat, and transport as necessary. Refusal form, but remember, if you're saying that this patient doesn't have capacity, then it's going to be someone else refusing on that patient's behalf. And then these are the cases that you want to document thoroughly. A way to say this is, I believe this patient did not have decision-making capacity because he appeared to be intoxicated with alcohol. He could not repeat the risks of refusal. This patient did not have decision-making capacity, and so we made the decision to transport the patient against his will. These, I think, are some of the most difficult calls we deal with. Any other questions about that situation? We'll go into more detail on the mental health issues as well. So you're documenting on the refusal form, documenting their capacity, documenting the contact medical control, and then, as we were discussing before, if medical control was not contacted, there should be a good reason, and you should document in your report why that was happening. Document what your advice was to the patient, what the further harm could result. And then obviously there are some patients who will not accept that refusal information form. If the patient is, so you're going to document what the disposition was on the refusal form, whether they refused everything, refused treatment and transport. If they're in custody, document the agency and the officer. So a patient in custody can refuse medical care. A patient in custody cannot choose the location of their incarceration. And so if this person cannot go to a jail without medical clearance, they can't choose whether they're going to go to a hospital or a jail, but they can choose to accept or refuse any parts of their care if they have decision-making capacity. If you're leaving the patient in the care of a relative or friend, document the name and the relationship, and then obviously sign and date the form.
And is there a decision with the capacity of the patient, what hospital they can go to, or just whether or not they're going to the hospital?
Are you talking about a patient who's incarcerated?
Yes.
So the question was, does a patient who is incarcerated get to choose which hospital to go to? And so I would, no, they can't choose, a patient cannot choose the location of their, someone who is incarcerated cannot choose the location of their incarceration. They can choose to accept or refuse IVs as long as they have decision-making capacity, accept or refuse other aspects of medical care, but what they cannot choose is the location in which they're incarcerated. Okay. So let's talk about the POST form. This is taking an advance directive and translating it into physician orders that can be acted on. It is not the same thing as an advance directive. It does not replace the advance directive. It's a specific set of physician orders. That said, the advance directive, if a POST is not available, can give you some guidance. So Part A of the POST talks about resuscitation if the patient is pulseless or apneic. Part B talks about medical interventions such as comfort measures, limited interventions, advanced interventions, and then full treatment. Part C includes the signatures of the patient and the primary care physician or a surrogate for the patient if the patient's incapacitated. It will also give us information about antibiotics, whether we can use any antibiotics or use antibiotics with comfort as the goal. And then Part D can include other non-emergency medical treatment preferences in addition to the antibiotics, whether they would want to be tube-fed. So it's for patients who have a serious illness or are towards the end of their life, completed by a healthcare provider, must be signed by a licensed independent provider. And often as a home, you should find it in the chart in a healthcare setting. So a patient can verbally revoke the order. A physician can revoke the order, or the legal surrogate for the patient can revoke the order. So this allows us to provide resuscitation based on the patient's wishes and provide the medical interventions that are indicated on the form. If we're always taking care to provide for the comfort of our patients, and then contact medical control if there's any doubt about how to interpret the form. So for comfort care, you can use medication by any route. You can use intranasal medication if that's appropriate. Positioning, wound care, many other things can help a patient become more comfortable towards the end of life. Oxygen, oral suction, removing airway obstructions, are other things that can be done to make the patient more comfortable. So if you are acting on the POST, you want to indicate that the patient is DNR by POST, record who the doc signing the POST is, why EMS was activated, and then document your contact with, so say you're terminating the resuscitation, document your contact with medical control. You're probably not going to be contacting the patient's physician directly unless they're on the scene, and then you document your contact with medical examiner and or law enforcement. One thing that's come up in the last couple of years, in Oregon, there is a POST registry, and there are a number of patients who live in Clark County who either have physicians in Oregon or have chosen to register their POST in Oregon. And so this is an electronic version of the POST that's available by telephone. This number is a 24/7 number. They say the average time for them to get you an answer on this is about 48 seconds. And so you can, you may see an Oregon POST registry ID. They give stickers or magnets to patients who have recorded their POST in the Oregon registry. Or you may get a verbal report that, oh, this, I don't have the physical pulse, but this person has a registered Oregon pulse. And then you contact this number, give them the patient information, and then they can give you all the pertinent information on the pulse.
How does that work out with the state forms though that we have here when we're making a phone call and Tom says, well, he wishes not to be resuscitated, but there's no actual form on scene?
So if a patient has no form on scene, but they have something recorded in the Oregon, so the question was, what do you do if there's no form on scene? So if they don't have a form on scene, but this patient has a pulse recorded in the Oregon registry, and you call this number and they give you the information, I would treat that in the same way that you treat a form.
So does that Oregon registry cover Washington's pulse forms as well too?
So the question was, does that cover Washington's laws for a pulse too? Yes. If a person has a valid Oregon pulse, we would treat that the same way. The forms are almost exactly identical, and we would act on it in the same way. And just because we border Oregon, there are some patients in Clark County who have Oregon pulse forms that's in that registry. Right now, Oregon is the only state that has a pulse registry. Other states may be doing that in the future, but it's going to be, in Washington, it's going to be a minimum of 3 or 4 years. It's a big project to set up and requires a significant amount of funding. Other questions about the Oregon Pulse Registry? And just to clarify, similarly to a form, if they had something recorded in the Pulse Registry, but then they verbally revoke it, or there's discussion, then just like you would with a form, the information you get on scene can supersede that. In the case where you have a valid form and there's disagreement amongst the family, continue treatment, contact medical control, and work to resolve the issue. But if there's disagreement, then err on the side of treatment.
How long can you take continue treatment? Is that just sticking with BLS until a physician's contacted, or continue with the BLS?
I would start with BLS procedures and hope that and then work to contact the physician as soon as possible. But if you're in the situation, so let me repeat the question. So the question was, do you do BLS procedures only, or do you move on to ALS procedures? So I would say, in the situation of CPR, your initial resuscitation is, the first 2 minutes of the resuscitation are going to be BLS measures. So I would start with those things. But if you're in the situation where you have a family member saying he changed his mind, he wants full resuscitation, do everything you can, then I would proceed with full resuscitation until you finally made an ultimate decision in discussion with medical control. Where you have discord amongst the family, it can be a very difficult decision. But I would not do a slow code, I would work if there's a disagreement, either full work the code or don't work the code. And so I would just fully work the code until the disagreement is resolved. Yes.
We have two physicians in here, but be on the other end of that medical control. We've always said this has kind of been a standard. We've always done it before. How are you guys going to respond to that when you get to the phone call?
So the question is,
Dependent on the situation? Let's just say it's that gentleman that's adamant. No, disregard the DNR. He wants to do something.
so the question was, as a physician, how do you respond to getting that call? And what I would say is, I would respond to it just like I would in the emergency department, which is if there's disagreement amongst the family, and it's clear disagreement and I can't resolve it, then I would continue with full resuscitation. There may be, so I may ask to have a conversation with say there's one dissenting family member, and I would say, is this, this patient has indicated that it's his wish not to be resuscitated, not to have these invasive procedures. Is there something that you've learned that makes you think that he's changed his mind about this wish? So I would really try to get at why it is that they're not in agreement with the patient's previously requested wishes. But if there was ongoing disagreement, I would continue with full resuscitation. Dr. Bell, do you have anything to add?
No, I think I think this is, when we get these calls, if we know that you have done your due diligence already in the field about, going through the thought process and deliberation with the patient, family, whatever, and then, and then we'll do whatever we can to support your decision and decision making in the field. We know that these are often very difficult situations, especially when other people are involved. And there may be people that come in and haven't been involved with the patient for some time, and then all of a sudden they're on scene and they know that they try to make the appropriate intervention.
Right. So Dr. Bell's comments were that we're, for the people who are not here, that we're going to support the decision making that you're making on the scene. We know you've done your due diligence, and we know this this phenomenon. This is my own words now. So this phenomenon some people refer to as the seagull child that returns from afar and does what seagulls do, and it can be a really difficult situation. But so we'll try to address that with the person and try to figure out what it is that's causing that disagreement. But if we can't resolve it, we're going to continue with full resuscitation. So let's take a 5-minute break right now, and then we'll go on with the rest of the documentation issues. Yes.
So,
So this is the Washington Administrative Code regarding documentation. None of this will be a surprise, I'll summarize the key points. So the person in charge of patient care should give a report to the hospital receiving staff. And then within 24 hours of arrival, complete written or electronic patient care report. So what is patient contact? So when you contact, see, hear a patient, even if there are other providers on scene, that's when you make patient contact. Anything that you do during that patient contact should be documented. And this just to emphasize, we exist in this role between public health, public safety, and health care. But when you're doing this individual patient contact, you're providing health care. And so that's participation and evaluation in a decision-making process, interviewing the patient, the family, the bystanders. Even if there are other agencies involved, your individual interaction should be documented. The patient care report is a legal document. It should reflect the patient care as accurate as possible and as soon as feasible after the patient encounter. And then I can't tell you how valuable it's been to have the written copy of the patient care report when we're taking care of the patient. The other thing that I would add to that, I find the 12 lead EKGs that are done in the pre-hospital setting incredibly helpful, not just for early STEMI identification, but I've definitely made the diagnosis of acute coronary syndrome just by seeing the change between the pre-hospital EKG and, say, we give the person some oxygen, some nitro, and they go back to having a normal-looking EKG, but the fact that they are having dynamic changes in their EKG is the clue, and that's the one thing that leads to the diagnosis. SOAP charting is acceptable. Obviously, most of us are dealing with electronic reports. This is a situation where people have gotten into trouble in the past. So attendance of the patient during transport will be appropriate to the degree of illness as determined by the paramedic. All ALS transports will be attended by an emergency medical technician certified to provide appropriate ALS procedures. The exception for that is in mass casualty incidents. The places where people have gotten into difficulty with this, because I understand, we want to get our EMT partners involved in the care. We want to give them a chance to assess patients. But for example, the patient who's fallen has a hip fracture. If it were you, if it were a member of your family, you would want them to have pain medication. If there's an indication for pain medication, that is an ALS transport. And this is something that is potentially legally fraught if you're not providing an ALS level of care when you're attending that patient. Questions about this? So this is a review of the disciplinary process. The grounds for denial, revocation, or suspension of an EMT certificate. Any misrepresentation in obtaining the certificate. If you engaged or attempted to engage in activities outside the scope of the certificate. If there is demonstrated incompetence, if you've falsified records, demonstrated unprofessional conduct, violation of patient care protocols, or a failure to maintain skills. And in general, it's much easier. We assume that we have all made medical errors. We assume that most errors made on scene are medical errors. It is much easier to deal in a disciplinary process with a medical error than with any kind of falsification of records. So these are the situations that require us to consult with the Department of Health. Any repeated failure to follow protocol or patient confidentiality. We just came back from the state medical directors meeting yesterday. I think the biggest potential pitfall that we face now for patient confidentiality is social media. And it's very easy to, particularly with a high profile call, even if you're not mentioning the specific patient name, if the details of the call are identifiable by your description of the call, and we know that Facebook is not the ideal protector of our privacy, much less our patients. Similar, those are the cases where people have gotten into the most difficulty. Use of alcohol or other controlled substance that affects the individual's ability to render care. And my personal take on that is that we do a stressful job. The people who are out in the field every day have an extraordinarily stressful job, and we are our brother's keeper. And so it is when we see the problems that recur most frequently are substance abuse problems. One of the things that came up in the meeting yesterday, a lawyer from the Department of Health was looking at an alternative to disciplinary procedures, but the people who are most likely to get into repeated trouble are people with substance abuse problems. So I just ask you to take caution for yourself and look for signs of difficulty in your colleagues. If you represent your qualification to be anything other than what you're certified to do, if you abandon a patient, if you alter your document, if you're on a probationary agreement and violate that, cheating or helping to cheat on a certification exam, attempting to assisting another in obtaining certification via fraud, forgery, misrepresentation, deception, or subterfuge, and then illegal distribution, administration, or dispensing of a controlled substance. Continued. So gross misdemeanor, particularly something that affects your ability to function, falsification of a patient record, and I've not dealt with this here, but in my previous job, you can make a medical error, but we can deal with medical error, but any falsification of the documentation are things that we have no discretion. We have to report to the state. failure to provide proof information and demonstration of incompetence, felony, failure to complete CME requirements or remediation, any violation of a rule or regulation, and then performing a medical procedure not approved by the MPD. Blood draws can be done if a patient is under arrest and there's a reasonable likelihood that such person may die as a result of injuries. So this is a situation that I know has come up. So if a patient, these are psychiatric disorders in which someone has a psychiatric disorder, for example, is suicidal, and is refusing transport, doesn't have the capacity. We touched on this 2 months ago when we did mental health disorders. So a police officer may, at his or her discretion, place the patient on a hold or take them into custody. If that person elects not, if the officer elects not to do that, and that person is significantly impaired or at risk to themselves or others, that's when you contact the designated mental health professional for the county. As a reminder, in Washington, unlike in Oregon, a physician cannot involuntarily hospitalize someone. That's only done by the designated mental health professional. A physician can detain someone for mental health evaluation, but cannot commit someone to psychiatric hospitalization against their will. So if you're in this situation, you explain the situation to the designated mental health professional, including your assessment, and then they may request that you transport the person to either emergency department in Clark County for an emergency evaluation, and they can instruct law enforcement to place the person in custody to facilitate that. And then when that decision has been made, you can use physical restraint, sedation per protocol to achieve that effect. Questions on this?
Is that a direct phone call to the medical health professional?
Yes, so you'll call dispatch, and they're on 24/7. They will.
So notifying dispatch, it's not like we call the mental health professional, then we calling us on the number we give dispatch?
They should call you direct. Do you have any? Yeah.
Typically, yes.
Yes. Yeah. But these are people that we're in touch with in the emergency department every day. They really do work 24/7. They are backed up, but they've made a commitment to be available to take these phone calls. Before we move on, any other questions about medical legal issues? Okay. So I have one slide for information only about hereditary angioedema, and I'll explain why we're talking about that. Then we're going to go on to do some reminders about the ongoing studies, and then Mark will do case reviews. So this is just information on hereditary angioedema. The reason I'm bringing this up is that we learned that there are 2 patients that had moved into the area who have hereditary angioedema and have this new drug that they'll have the first dose in the house, and then we have subsequent doses at the hospital. There's no change in your protocol. There's no change in how you would treat these patients. But I'm just saying this to make you aware that this exists, so it's not coming completely out of left field should you be called to treat these patients. So first, background on hereditary angioedema. Sudden onset angioedema with or without urticaria. It can look similar to an allergic reaction or ACE inhibitor angioedema, and it's treated in the same way. So there's no need to change the protocol. There's no need to do anything different. The only thing I would say is that these tend to progress a little bit more slowly than allergic reactions and a little bit more slowly than ACE inhibitor angioedema, but they can be treated with epinephrine. They can be treated with, and I'd say your IV drip of epinephrine is appropriate here. They can be treated with steroids. They can be treated with Benadryl. And in the case where the patient is not responding to those situations, it's possible that they would require rapid sequence intubation. So these patients that we've learned about have a medication at home called Kalbitor. Ecallantide is the brand name. It's a kallikrein inhibitor, and it's an injection that they may give themselves in the home. The patients that we've learned about have a letter that's clearly visible in the house to give to healthcare providers, and And so the only thing that you would expect is that hopefully it would decrease the symptoms of the allergic reaction. You would, again, treat them as you would for any case of angioedema. They'll have, I've obviously got a notification of the patients that are at Salmon Creek. It'll be part of this letter that there are additional doses for this patient at Salmon Creek Hospital. And so they'll request transport to that facility. And to my knowledge, no patients have contacted Southwest, but there's no reason that they couldn't contact Southwest and have that as their preferred hospital in this situation. Questions about that?
Does that drug change the effectiveness or the potentiate our medication, or is it no factor?
No factor. I mean, it works through a different mechanism, and so you treat them just as you would any other patient. It's difficult to predict the course of these, and so you would hope that this would get better. But I would just treat it as any case of angioedema. It's obviously some helpful information to get in the HERE report, because then we can start to get that medication down from pharmacy. But it's you would treat them. I wouldn't expect a significantly different response than you would see in other cases, and I would treat them just like anyone else who has angioedema. Just for background, of all the cases of angioedema we see, probably about 90 are allergic reaction, and then about the other 9 out of 100 would be ACE inhibitor angioedema, and this is maybe 1% of the angioedema that we see. Okay. So reminders about ALPS. So last week was the scientific review committee meeting. The Data Safety Monitoring Board has met. They recommend continuing the study. What I can say is we still in Clark County lead the metro area. And this is what was expected for the study. We're expected to go on for 4 years. We're in the 3rd or 4th years. Clark County is still in the lead in the metro area in enrolling the highest number of patients. And so my hope is that we're going to answer this question. We're going to know about what the best drug is to give for resistant VF, but it's just imperative. We're overall nationwide, we're behind where we want to be in terms of enrollment. Pittsburgh is now starting, and that should help, but it's just imperative that we catch every case we possibly can. Throughout the metro area, we're catching 90% of cases, but any additional one we can pick up will help to complete the study. So indications: non-traumatic out-of-hospital cardiac arrest, for which you have an IV or an IO, persistent or recurrent VF, so second shock, think rock, no open-label amiodarone or lidocaine use, no known hypersensitivity, no prisoners, minors, pregnancy or trauma deaths, no one with a no study bracelet. Anything but an ICD shock counts as a shock. Persistent or recurrent VF is anytime you are seeing the second, even if they change into another, you shock them, they change into a sinus rhythm, then go back into a shockable rhythm, that counts as persistent VF for VT. So you want to give the drugs as soon as possible. If you have Roski and then you return to that, you give the remaining syringe. Late occurring, such as say you get through several rounds of treatment for PEA, then you have VFib, give the drug, and then if it persists, do additional shocks. No amio or lidocaine, but you may use magnesium. Use the ClearLink adapter. If the syringe is broken, they're excluded. Call this number, and people have been doing a fantastic job of doing this. Even if the kit is opened without giving it to the patient, call this number, and then upload the CPR process files. Very helpful for the data collection. Sudden unexpected death study is still ongoing and will be ongoing for some time. This is transport agencies, patients with pre-hospital cardiac arrest that's not traumatic and not known overdose. Blood is drawn after the IV or IO start. And then the tube is labeled, your crew number, the date of service, a copy of the hospital face sheet if you did transport the patient, and then it will go in the ambulance cooler until that ambulance returns to headquarters. And that is all I have, and Mark will come up and do case reviews.
Okay, we can start. There we go. Really? God. Hey, I never said I was bright. All right. Okay. 20-year-old guy. This was a Camus case, and I think some of you are here, or actually here, or on this call. Actually, Paul. The guy was, sorry, didn't mean to call you out, but it's a great case. It was a great case. Guy was driving a side-by-side all-terrain vehicle. Alcohol was involved, from what I understand. Sitting next to his buddy, wasn't helmeted, lost control, struck a power pole, flipped the all-terrain vehicle. He was actually going pretty fast, I guess. But it did have a roll cage, which was good. Patient ejected 15 or so feet away from the vehicle. However, his buddy was up and did not have any chief complaints at all. So his buddy says that patient was immediately unconscious after the incident. He ended up having to put a tourniquet on the patient's left leg because it looked like he was bleeding out, pretty significantly injured. Alcohol was involved. And you guys placed Lifeline on standby on the way there, or did ECFR?
I did.
You guys did, just because you knew where it was and
Yeah,
one was away.
and saw the updates. Fine.
Okay, cool. GCS of 8, cool, pale, dry skin, blood noted from his mouth, no facial trauma, pupils are dilated at this time, bilaterally, disconjugate gaze, no tracheal deviation, equal expansion, good tidal volume, soft, non-tender abdomen, no injuries to the right side for the most part, left arm, because he was a driver, obviously, and he flipped onto his left side. Partial thickness injuries of his upper extremity. Significant injury of his left leg. No arterial hemorrhage noted, but it sounds like he was oozing the whole time. Partial amputation of his proximal left leg with exposed femur. Well, it was nasty, okay? Hence the tourniquet. Tourniquet was left in place. The activated lifeline put him on a seat collar, log rolled onto a backboard. Heart rate was, he's tachycardic, he's tachypnic, but he's relatively normotensive for a guy who's been drinking and probably has a history of same. They put in an IO, took him to the LZ, and O2 sat increased from 62 to 88. He starts to moan, pull at his seat collar. You guys did RSI, which was really good. Got a good positive waveform. Got to the LZ, life flight landed. Gave him further Versed, which is probably a good thing considering it's going up in the air. And then he was transported to Peace Health Southwest. So do you want to give a brief little rundown on what the issue was?
Oh, with the time?
On scene with the times and things like that.
Well,
Yeah.
I think there was just some problems. I think just with when ECFR arrived, I think that kind of time-stamped the arrival of all of us.
Right,
And
right.
so it showed that our on scene was extensive, like 40 minutes, which it actually wasn't. They couldn't have gone any faster. Basically, when I got there, I assessed him. I mean, it probably took me 20 seconds. Activated life flight.
Mhm.
Did a quick primary, secondary. Instructed Andrew to initiate placing the patient in pharmacautions. I went in the back, spikes the bags, prepared for RSI. Got the monitor up and ready. By then, patient was in the back.
And Lifelay was pretty close to being there when you got to the LZ? Or you were there for a little?
It went like clockwork.
Yeah.
The LZ was probably, what, maybe 3 miles away, 2 miles away? Yeah. They overflew us and went to the scene eventually. Yeah.
Yeah.
And so it worked out actually really well because we got the IO en route, started backing them, cutting clothes off, got further vitals into the secondary, got all the RSI meds. We got to the LZ. I placed the tube, and it was pretty much right when we got a waveform. Life flight arrived, the nurse came in.
Right.
She requested second first ed, and she was going to get some, and I was like, well, we have some. So got the first ed, and he was off.
That's why I bring the case up. This
So I
is,
don't know why the times were so skewed, because
Yeah.
to me it went like clockwork.
yeah. It originally showed about a 40, 45-minute on-scene time, but that was because of the first response timestamp that happened.
Yeah.
So it was a,
Yeah, I don't think we were longer than, I mean, on scene, I don't think it was any longer than 10 minutes.
yeah, yeah. So I bring it up. It's one of the few lifelike cases that actually worked the way they're supposed to work. It's a classic example of the benefit of having a helicopter when, you have difficult extrication from the area in which you are. You have longer transport times. It was a good example of helicopter use. Yeah.
What do you think was helpful to you in getting the tube so quickly and blooding your airway with the King
That
Vision?
King Vision it's awesome. I've had the opportunity actually, been a little bit of a black cloud in a way. In 3 shifts, I've had three chances to get innovations. I gave the last 2 way after this one. But all of them, they work really slick. One thing with the King Vision is make sure to suction out the oropharynx prior to insertion because it will skew the camera. So get all the spools out of the way. And then just make sure to follow that tongue, and it's just right there. And then also don't lift like a regular surgical blade. Actually use a little bit of a prying motion. And then we use the bougie also, and I just fed the bougie through, and then
In the channel.
And
Yeah.
it worked really slick because it would have been a very difficult tube because he was a big individual, short neck. He was a little bit clinched with the head injury, but it was textbook. I mean, it worked right there.
Yeah, good case. So the take-home message is the King Vision works really well as long as you have suction and the benefit of preloading. Did you preload the ET tube with the bougie?
Yeah.
Yeah. Yeah. Okay.
I would use the channel.
And the channel blade. Okay. Good. Good. Hospital course for this young man. He was intubated, sedated. He had a mild subarachnoid hemorrhage. Mostly his head injury was from, he was concussed for the most part. Multiple lower extremity fractures. His left leg was avascular. What essentially happened during his injury was during his ejection and rolling, the vehicle landed on his leg and kind of stretched and tore essentially everything. So his left lower extremity was avascular. They originally tried a below-the-knee amputation. There was no salvaging the lower extremity. They originally tried a below-the-knee amputation, which after a couple days, that did not work out because he started to develop infection and other issues. So they had to revise his amputation to mid-femur, mid-thigh, which is unfortunate considering his quality of life. After that, it's much more difficult to develop prostheses for an above-the-knee amputation than it is for below-the-knee. That's why they always try and maintain the integrity of the knee itself. He also had a ligamentous injury, which resulted in a C2 occipital fusion, which is a bummer because he's going to have to say yes and no from now on. I'm here all week, I know. Currently, but fortunately, he had no neural deficit from that injury. So it's, God loves a drunk, I guess. That's.
I went on him a couple years prior to that, similar incident where I darted his chest.
Yeah, he's chasing Whitwer for entrance into the trauma system, actually. All right. Is this the case that went to Legacy? I'm thinking I can't remember. 5-week-old male, lethargic, responsive to painful stimulus. Prior to 2 response, Delta response to a breathing problem. I think it was. Mother greets crew at the door, appears very calm. When asked, what's wrong with your baby? She said, I'm not sure. He's kind of having a hard time breathing. I think he's sick. Remember, he's 5 weeks old. During transport, patient mother relates patient has had this issue since the prior evening, but then was not lethargic. Okay, so makes your radar twitch just a little bit, I would say. She said this happened when she was giving him a bath. She noticed a significant change in the way he was acting. He suddenly became listless with trouble breathing. On arrival, patient's limp, pale, breathing slowly, airways open, his respirations are labored and slow. 4-second cap refill is pale, so probably hypotensive. No other real abnormalities other than he's limp, doesn't have purposeful movement, he's pale. After therapy, he starts to pink up a little bit. House is full of cigarette smoke and was very unclean. Mother's detached and caring, unkempt. Baby's clean but smells like cigarette smoke even after giving him a bath. Patient had minimal reaction to heel stick and rectal temperature check. Code 3 to Peace Health. No, it's a different case. Heart rate 110s or with blow by O2. Blood sugar's 94. Is that okay for a 5-week-old? Yes, no? No, probably not. High 90s, O2 sat. His rectal temp is 98.5. Cap refill becomes less than 2 seconds with O2 and a little bit of stimulation, I guess, actually. And then the important part of this is this is one of those situations where it's really important to note and report the conditions that you find the patient in, because this ended up being a CPS referral. Unknown cause for the lethargy as of right now. Patient was getting worked up for sepsis, and they found out he was actually being treated for thrush, what's the typical treatment for thrush? Anybody have any idea? In babies? Is this going to cause them to be lethargic? The thrush itself. What is thrush? Does anybody know? Yeah, it's a yeast infection. So you treat yeast with anti-yeast stuff. But it can also be rather uncomfortable. I mean, you don't spray Monistat in their mouth, but God, I'm on it. All right, so it can be uncomfortable, so they can receive sometimes kids get pain medication for this, okay? Adults typically they're treated with codeine or some sort of pain medication. So this might be a cause of his altered mental status. Anyways, it might be, it wasn't in this case. Living conditions, this ended up being a CPS referral issue, and there was an issue with parental fitness. Young parents, multiple kids. Basically, I guess they have babies as an investment. So, interesting case. This patient has a history of peanut allergy. Patient sitting on sofa holding a med neb, conscious, alert, oriented, anxious, trying to pull the med neb off, unable to sit still. Patient's mottled, ALS fires on scene already. Patient's stating she's having an allergic reaction, confirmed by fire, to food. Lung sounds are coarse. That's why they started the med neb. SpO2 is upper 80s, which really isn't so good. 89 actually. Albuterol or med neb's given. IV has started. GCS is 15. She's alert, oriented. Oxygen as well. Epi drip is begun at 4 mics per minute, increasing. Then the drip is DC'd. Any idea why? Just out of curiosity, just knowing what you know so far. Her skin becomes pale, cold, clammy. Yeah. Good call, actually. She developed sinus tachycardia as a result of the epi-drip. Blood pressure is now 110 by palpation. Respiratory rate's 30, shallow and labored. Benadryl's given for the other allergic reaction signs. Let's see, nasal airways started. Ventilations are now assisted. Vascular access has started. So the epi-drip was DC'd because of the increased heart rate. Second IV has started at this point. Patient becoming extremely pale. No, not as of yet. Deteriorates to unconscious. It is a good question, though. Actually, I mean that's a kind of a normal segue from she's getting really crappy to now she's crappier than crappy. Nasal airway is confirmed. Upon arrival to the hospital, patient goes into cardiac arrest. CPR started and then transferred to staff, and you're like, holy shit! But this is one of the reasons why we started the institution of the epi-drip thing versus, could you imagine back in the, I don't know, for the old days when we used to give epi-boluses for allergic reactions, even though if they were 0.3 milligrams sub-Q or IM, whatever we'd try to do at that point. Okay, one of the things that wasn't mentioned originally, which EMS really didn't know at the beginning because she was in extremis and they were trying to treat her shortness of breath, is she has a history of cardiomyopathy, bundle branch block, mitral valve regurg, so she's got issues. Non-compliant with her medications. She was intubated. That's supposed to be cardioverted for probable A flutter. She developed pulmonary edema, and they treated her for cardiogenic shock because her ejection fraction was 10 to 15%, which is pretty low. She was admitted. So basically, they treated her for underlying pulmonary edema due to her medical history. She was admitted, intubated, extubated day 5, and they managed her shock pretty much with fluid and pressors like they normally would, and then they DC'd her home relatively in the same condition in which she was admitted. So anyways, you'll see her again. But one of the take-home points with this is that the epi-drip, it still can be problematic in patients with medical histories like this. Yeah, Marlo, you have some?
Could I make an announcement after your last case?
Sure, yeah. So, any questions about that? It's a good case, good care, did everything they were supposed to do. Unfortunately, patient's underlying medical condition made it problematic. Yeah?
Was there an allergic reaction?
There was. Yeah, she had curry that had peanuts in it, and she was allergic to peanuts.
I know hindsight's 20/20, but wouldn't, if the patient was experiencing anaphylaxis, wouldn't tachycardia also be possibly a sign of worsening anaphylaxis?
Absolutely. Yeah, absolutely. It's it's one of those. Hopefully, it's a balancing act because she's gonna cack from one or the other. So you kind of pick your poison and do your best in that case. Yeah. You might lighten the epidose and drip it a little bit slower, or try to anyways. Okay. Code 3 on unconscious. Guys at the gym working out for about an hour. He goes into cardiac arrest at the gym. Staff does CPR, which is great. We need more citizen CPR equals more pre-hospital ROSCs. The staff at the gym also defibrillated him with their AED one time. Apparently they know him. He's had a heart attack about 3 years ago, and since then has lost about 100 pounds. Maybe an indicator that losing weight isn't such a good thing. I don't know. Yeah, exactly. Okay, upon fire arrival, the fire gets there, AED still attached, no shock advised at the time. Patients on the ground, assisting ventilations and starting a 12 lead. Patient's conscious, wake, and oriented 04, GCS 3, pink and clammy, face is intact, blah, blah, blah. Patient has a very large tongue with blood, spit, and foam in the mouth, fluid in his lungs, and he has agonal respirations. Why does he have fluid in the lungs? What are you thinking, maybe? What are some things that would... Maybe aspirated, pulmonary edema, we're not sure yet. So the AED goes off, then EMS shocks him once, then shocks him twice, gets vascular access, peripheral IV rather than an IO at this point. Patient's moved to gurney, code 3 to Peace Health. He develops a blood pressure, 220 over 130. He's supine, respirations are 10. And I can't tell if that's assisted or if that's his. That's a pretty important thing to document if you guys can, whether the respirations are assisted or not. 12 lead is done. He's got a fib, CO2 of 35, which is good, so we're thinking ROSC with this. Difficult airway. They attempted king vision look, unable to visualize due to blood and secretions. So ventilated with BVM, started to suction him, unable to insert an oropharyngeal OPA due to gag, develops agonal respirations, BVM assisted. So we start the RSI sequence, tried the king vision, but had lines in the picture area. What's the problem with that? Yeah. So how do you fix it? Turn it off, turn it back on. Okay, good. Tried to fix, but unable to get the lines to go away. Tried to tube conventionally, but unable to see the cords. Actually, that was still with the king vision. What do you think the problem was in this case? So, turn it off, turn it on, try a new blade, actually, if that's an issue. Check your pulse. Make sure your pulse is okay make sure you really turned it off, okay, and not just wished that you turned it off. Try a different blade, actually. Okay. Tried the tube, unable to see the cords, pulled the king vision, but ventilated with the BVM. What are one of the other things that we would have liked to have seen here? iGel, absolutely. Otherwise, difficult tube, but a life lesson in the importance of suction, and using I don't see the bougie being documented, but that thing makes life really, really easy. If you preload the ET tube with the bougie, because that way there's less material to go into an airway initially. Okay, so suction and use the bougie, but difficult airway nonetheless. In hospital, patients intubated in ED, had an acute STEMI with VF arrest. He went emergently to the cath lab with a cabbage ×4 AICD placement, and DC'd 9 days after admission with CPC of 1, which means that he was essentially normal. So it was a great case, well treated. Thank goodness for early CPR, early defibrillation, and despite the difficult intubation, they were still able to ventilate okay. Question? Was ALPS given? That's a very, very good question. No. ALPS wasn't given in this ALPS wasn't given in this particular case. The issue with this was, let me show you. The issue with this was that he converted, patient converted. This was a mistake, obviously. Patient converted originally, and due to the airway issues, the ALPS wasn't given. Patient was shocked 3 times. So, anyways, good point. Yes, ALPS should have been given. Last case, interesting situation. This guy had a dispatch to a ground level. This is the dispatch information, possibly dangerous. Patient's lying on uneven grass in a pebble driveway of his house. He's in his mid-70s. He's conscious, awake, and oriented times 4. Full sentences. Fire is holding manual C-spine. He's complaining of right-sided neck pain and that his throat feels thick with phlegm, like he's choking. His neck is tilted to one side, and he's unable to straighten his neck. Okay, ground level fall, 72-year-old guy, unable to straighten his neck. Okay. Why can't he straighten his neck? Any ideas? Is that because it hurts? Yeah. I'm not going to move my neck because it hurts. That's a good sign to probably immobilize it in position found, which is what they did, which was very, very good. Blade on the long backboard. Patient began to gag and choke. He can't breathe. He's choking on something. Something stuck in his throat. So they put him in a KED in a seated position, which is good. No relief with fentanyl. Trauma alerted to Peace Health. Okay, we did that. That was great. Gave him some Zofran for a little nausea, which is probably a good thing. Vital signs are stable, 136 palpated. His heart rate's only 78, which is good. Kind of makes you want to consider what his medications are, right? Okay. In hospital, he had a ground level fall. He landed on his face on uneven ground. He had a Jefferson fracture with a fracture of the dens. Okay, so he had a Jefferson fracture is a fracture of the C2 or the C1 ring, essentially. So he, and the dens is that little bony protuberance of C2 that goes up into C1. So he had a pretty significantly high cervical fracture. He decompensated. He required, so he essentially decompensated in the ED, required intubation, which they couldn't tube him, so they had to perform a crike. And the last information that we got is they had to surgically stabilize C1 to C3, which basically means he's going to be saying yes and no from now on as well. So I don't have any further follow-up on him, but a pretty significant injury for a relatively low mechanism. Okay, and a really good job by EMS on figuring out a way to. Most of the time, we can put manual stabilization for C-spine is pretty easy. We put him in inline position. This, he was physically unable to move his neck back where it needed to go. And if you would have done that, if you would have reduced his fracture, you probably would have pithed him right there. This is a really good case of how to manage a difficult situation. So, any questions about any of this stuff? Oh, yeah, I'm done.
So I'll take 30 seconds and then we'll get you out of here. I'd gotten some questions about this. So as a reminder, on the first Tuesday of every month, we were doing triage tags. The goal of this is to test our system's ability to triage and track multiple patients. And the only way we're able to stay familiar with that is to practice on a regular basis. We're obviously reminded with the shooting in Gresham this morning that thankfully seems to have a small number of patients, but our system may be tested in its ability to care for multiple patients. That's the reason for doing this. Welcome any questions about that. Please just record basic information, the patient's name and vital signs on the triage tag, and we'll collect them at the hospital, and then we're reconciling them after the fact. Any questions about that right now?
The question came up if you should put that in the patient care report, and my answer to them was no. Do you have any initial on that?
Should you put the triage tag number in the patient care report? I would say there's no downside to doing that, and it could potentially help us reconcile the triage tags. But if you put more important would be to put the patient's name on the triage tag, because in real time, that's actually how we're going to be trying to pull those together. Other questions? Okay. Thank you very much.
I think that was my